All right, so we are now at the top of the hour. Again, I'd like to welcome everyone to this IAS-USA webinar. Today is Tuesday, September 20th, 2022. My name is Jose Francisco, and I'm a project manager at IAS-USA. We are excited to cover today's presentation regarding the rapid review of data presented at the 2022 International AIDS Conference. We are delighted to welcome Dr. Marina Klein, Professor of Medicine at McGill University in Montreal, Canada, who will moderate our question and answer session at the end of this webinar and will also be covering the introduction slides. Welcome, Dr. Klein.
Thanks so much, Jose, and welcome everybody. Thanks for being here today. It's a really great pleasure to introduce to you our speaker today. It's Dr. Paul Sachs, who I think needs really no introduction. He's the clinical director of the Division of Infectious Disease at the Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. And he regularly shares with us his extensive knowledge on HIV and infectious disease and clinical trials related to HIV, which he has been involved in for many years. And through this preparation for this presentation, I also learned he's a closet Montreal fan. So it's a pleasure to have you with us today.
Thanks, Dr. Klein. I fully admit to being a Montreal fan.
Just a few, before we get started, we have a few slides of housekeeping. These are the disclosures for the content of the web from the board that can be found here. On the next slide, we have the disclosures for myself and for Dr. Sachs. Just to remind everyone that this IAS-USA webinar designates this as a live activity for a maximum of 1.25 AMA category credits. And it's also been approved for the following other credits. And if you need instructions, you can claim them at that link to that website. We have received generous support for this activity from the following contributors. And this on-demand recording and the slides from this webinar will be made available within 24 hours of this live broadcast and can be found by following this link. And just a few items to remind you of how to navigate this activity. So there will be sporadically throughout the presentation some poll questions that will pop up in a window, and then you choose your response, and then the responses will be displayed after that poll closes. We really encourage you to be interactive in this presentation and to submit questions, but really remind you to use only the Q&A button because we cannot monitor the chat for questions. So any questions should come through the Q&A button. I will do my best to address as many as possible, but we only have a limited time, so hopefully we'll get to all the most of them. And finally, the chat is open. You can use it to discuss with other attendees, but remind you that the questions here will not be moderated. And without further ado, I'm going to turn this over to Dr. Sachs.
Thank you. I'm going to start sharing my screen now. Appreciate the introduction. And as I mentioned, I am very much a fan of Montreal. And I'm such a fan of Montreal that I'm going to show you some pictures of Montreal momentarily. But first, some interactive questions. Did you attend the 2022 International AIDS Conference in Montreal? And your options are yes, in person, yes, virtually, or no. Okay, waiting for your votes. And just so you know, this is actually the first scientific conference that I attended since the pandemic. So I don't know about you, Marina, whether this was your first one, but...
Yes, it was. It definitely was.
90% of you did not attend. 2% attended in person, and 8% attended virtually. Okay, now we have some learning objectives, and I always like to make fun of learning objectives because no one ever kind of looks back on the learning objectives at the end and said, what about those learning objectives? But anyway, here they are. Describe the data and apply it to care management of people with HIV. So let's do some pretest questions. You're going to get to vote on this. You have a patient who's newly diagnosed HIV. On baseline evaluation, he's found to be hepatitis B surface antigen positive. Further testing reveals a positive hepatitis B antigen, hepatitis B DNA of 8 log. The baseline CD4 cell count is 640. Viral load HIV RNA is 6,000. No HIV resistance is detected on genotype. and the HLA B5701 test is negative. Which of the following therapies should be chosen? I put them in alphabetical order. Bacavir, 3-TC, dolutegravir, bictegravir, FTC, TAF, dolutegravir, lamivudine, or TDF, 3-TC, doravirine. So I'm going to go ahead and vote. And you can see that it's A, B, C, D, or 1, 2, 3, 4, but they correspond. It's not a secret code. Okay. Waiting for the next slide. This is a patient has been treated 3 times for bacterial sexually transmitted infections over the past 2 years. He is currently on cabotegravir every 2 months for pre-exposure prophylaxis. Which strategy reduces his subsequent risk of contracting another bacterial sexually transmitted infection? 1, switching to PrEP to oral TAF-FTC or TDF-FTC. 2, cefixime 400 milligrams taken once after sex. 3, doxycycline 200 milligrams taken once after sex. Or 4, monthly benzathine penicillin 2.4 million units given intramuscularly. Okay, and you're going to vote on this one too. And these were specially chosen questions to reflect the content in the AIDS 2022 meeting. That was very clever of me to include this, but you'll get to hear about the various studies that might support one or the other. Okay, great. So it was 7% switching to oral PrEP, 9% cefixime, 77% doxy, and 7% penicillin. So I'm not going to tell you. What I'm doing is going to start by welcoming you back to Montreal. If you go way back, there was actually an AIDS conference in Montreal in 1989. Now, I may be old, but I'm not that old. I actually was a medical resident in 1989, so I was not yet an HIV ID specialist. But this is an important meeting because at the time, remember, there was only one HIV treatment. It was Adovidine, and there was tremendous concern about rising numbers of HIV cases. And soon after this, actually, AIDS became the leading cause of death among young adults in the United States. So it was really a very important activist action. And also shortly after this, there was a lot of engagement with activists from the scientific community, which definitely improved the pace of and the study designs that were done in HIV therapy. The first time I was in Montreal, though, was in 1967. My parents took me to this World's Fair, which you can see by the outfits of the people wearing them. It was a very 60s event, and it was an extremely exciting for me as a boy, because yes, I'm that old. I was alive during this time. They had this incredible amusement park called La Ronde, which is still there, and it was very exciting. 67, Expo 67. In fact, there was this new building there. This is Moshe Safdie's habitat. This was, believe it or not, a graduate student in architecture who put together this new way of constructing apartment buildings, and very award-winning, very exciting. Now you're saying, I didn't take this webinar to learn about Montreal, and I'm going to stay with Montreal and go fast forward to 2009. This is the second time the AIDS meeting was in Montreal. This was CROI 2009, and you could tell from the style of my PowerPoint that things have evolved since then. This is my summary after that CROI. And now I'm going to ask you a question. I'm going to say, what were the hot issues in the 2009 Montreal CROI? And I'm going to ask Marina, as a Canadian, to comment about these pictures that I have. What are these all about?
I was going to say one of the hot issues was how to stay warm. Yeah, so unfortunately, this is not what Montreal looks like most of the time. It certainly wasn't that this summer. But unfortunately, we had a massive thaw the week before CROI took place in February, and everything melted. And then we had a sudden freeze. And so there was ice everywhere.
But anyway, I think I'll remind you, those of you who've been doing HIV for a while, We were still in the when to start debate. We had a trial called SAPIT, which was about treatment of TB and antiretroviral therapy and when they should be started sooner rather than later, especially for advanced disease. The infamous switch-merck study that I like to tease Joe Aaron about, showing that if people stable on lopinavir, ritonavir, switching to raltegravir would get breakthroughs if they had nucleoside resistance. A lot on abacavir and cardiovascular risk. A large international study looking at interleukin-2 and how it raised CD4s but didn't seem to help anybody. We got introduced to a booster called cobicistat, which we hoped was going to be better tolerated than ritonavir, but turned out to be very similar. And then some early glimpses on treatment as prevention, which of course later became a standard reason why we treat people with HIV, but that was 2009. So, and oh yeah, ICE. That's another thing. Okay, so on to current Montreal. It's a beautiful city. There's this big park in the middle of it. You climb up to the top, and it looks down on the gorgeous city, and the city streets look like Europe. This is Montreal. It's really a beautiful place, and I highly recommend visiting if you have not done so. As promised, though, I'm going to cover the meeting. And I've enough on Montreal, but I do recommend you go. I've been now, let's see, Croix, vacation as a boy, vacation as an adult. This was my 4th trip to Montreal, and it's really wonderful. Let's start with epidemiology and prevention. This is UNAIDS often releases its global numbers around the time of the meeting, and they did so this time as well. And they 38.4 million people living with HIV in the world, 1.5 million new cases per year, and 650,000 deaths. So things have improved enormously from this low point here in the early 90s. But our targets have not been met. We had these 90-90-90 targets, and we didn't meet them. So by 2030, we'd like to be 95-95-95, 200,000 new infections, not 650,000, and of course, zero discrimination. So here's an interactive question. The goal by 2030 is to have 95-95-95 to 200,000 new infections, down from 1.5 million today. Will we achieve this? So what do you think? Opinions. Let's see what you vote, and then I'll ask Marina to weigh in. So you choose one or the other. 2030, that's 8 years from now. So let's see the results. All right. 63% are pessimists. 37% are optimists. What do you think, Marina?
Well, I hate to say I fall a little bit on the pessimistic side, and I actually did a presentation with respect to the fact that we've made so much progress in getting antiretroviral therapies much more widely available. But as we see with most infectious diseases, the upfront 90% is, even though difficult, the hard 90% and easy 90%. And then the last 10% or 5% to get there, that's where the real work has to go, because these are frequently people who are disenfranchised from health systems, or more marginalized, or not diagnosed yet. And so if we're going to get there, we really are going to have to step up our work, and particularly community-based settings, to really reach the people who aren't connected to health services.
Yeah, no, excellent point. And then another thing that's going to make this a challenge is certain parts of the world where HIV is most prevalent, like sub-Saharan Africa. There's still quite a lot of late presentation. Now, late presentation, these are data from Africa presented at the meeting. Now, note that this is from a little bit outdated, but still, it was over 4,000 people, and very high proportion of people with late presentation. So that's sort of the bad news from sub-Saharan Africa. The good news is that some countries, notably Botswana has actually achieved 95, and they have definitely a declining incidence, and they also have essentially eliminated mother-to-child transmission, which is amazing. So it is doable in all regions of the world. One thing that this last bullet shows is that late diagnosis is more common in men than women, and that's That's been true of virtually everywhere it's been studied for whatever reason. And then we've got next is about another population that's been very difficult to reach in the United States, at least. I'm pretty sure this is true in Canada as well. Trans women, and they have very high HIV incidence. And you'll note that the incidence over time, followed longitudinally, is even higher among the Black trans women, so that it's nearly 10% over the 46 months of follow-up that was seen here. So this is a target population for pre-exposure prophylaxis. It's very, very important because of their high risk of acquiring HIV. Now, one thing that is looked at periodically in the US is who is getting PrEP. This is a ratio of the number of people getting PrEP compared to the number of actual new cases. So it's a sort of a funny metric because it doesn't really have units or anything, but you would hope that the number of people getting PrEP would be proportional to the number of new cases. But in fact, while all of these groups had increased PrEP use over time, the group that had the fastest increase was the whites, and the whites have the lowest HIV incidence in the United States. So there is a strong implication from these data that we're still not getting PrEP to the population that needs it the most. And at least in our country, that is Black MSM in the South would be an area that's very important to target for PrEP. So let me switch now and talk about some familiar clinical trials to you. One of them is the famous HPTN 084 study, cabotegravir versus oral TDF-FTC. I'm sure the study design is familiar to you all. I feel like it's important to mention this because not all studies are double-blind, but this is a double-blind trial. That meant the people randomized to get long-acting injectable cabotegravir also took oral PrEP in placebo form, and people assigned to get oral TDF-FTC also got long-acting injectable placebo. And so there were a lot of injections given in this study and in 083. So the study, people who ran the study are to be credited. And what was new about this presentation was that this looked at new infections during the 12 months after the unblinding, and just to see whether they still had benefits seen. Because remember, in the first phase of the study, long-acting cabotegravir was superior. So let's take a look at the results. So in the blinded period, we have a significant reduction in HIV incidence, cabotegravir versus TDF-FTC, and this is a powerful enough effect that the study was stopped early. And then in the unblinded and blinded phase together, the ratio stays the same. It's still about a 80 to 90% risk reduction. So I am going to also mention that during this period, during this unblinded phase, there were no new infections with people who were taking cabotegravir as directed. All the new infections that happened in the cabotegravir arm happened to people who either didn't take their oral lead-in, that was at the beginning, or they actually were not taking their injectable cabotegravir, so they were not adherent to that. So very impressive results. This is one of the cases that happened. It was a person who had randomized to cabotegravir. There's this oral lead-in period. You can see that in hindsight, the levels of cabotegravir were undetectable. And then the person unfortunately acquired HIV between the time they enrolled in the study and that they got their cabotegravir. And then they had took, as you know from other studies, it took a while for the diagnosis to be made, but in hindsight, the viral load was 8,000. And then it was 1,300, and then it was indeterminate because they get partial viral suppression from the injectable cabotegravir. It's very tricky. So far, at least in our experience, which is limited, we have not seen one of these confusing HIV acquisitions in cabotegravir PrEP patients, but when it does happen, it's going to be extremely challenging for all of us. All right, So now I'm going to ask you a question. You thought that you would just be able to sit there and passively watch, but you have to participate. So injectable cabotegravir is superior to TDF-FTC in both HPTN 083, that's a study done in MSM and trans women, and in 084, which I just showed you in cis women. So should it be first line? And your options are yes or no. Those are it's pretty easy. And notice that I did not put a cop-out answer here, which could be it depends. But that would have, I want you to tell us what you think. All right, so let's see the results. So 65% says yes, and 35% says no. Marina, what do you think?
Well, I think if we don't say that this should be first line, it really limits our ability to use it, right? And this has been one of our challenges, I think, especially trying to talk to payers, for example, in our country, and I suppose in yours, because this really is a superior option. And I think its implementation is what's really going to limit.
Totally. So we it is approved for PrEP in the United States. Is it approved for PrEP in Canada?
Nope, not in Canada. No.
Okay, so
we were ahead of you to approve it for treatment, but not.
That's true. So cabotegravir is approved, but its use has been relatively modest so far, and it's because it's more expensive. And the other thing is that, if people take the oral PrEP, it's just as effective. It's sort of like you're taking the adherence piece that in long-term PrEP users out of the equation because they're more adherent to the injectable option. That was true in both 083 and 084. So it's been small numbers of people are on injectable cabotegravir. I think it's going to increase over time because the study results are so persuasive. But the people adherent to oral PrEP are having just as good a results as people taking cabotegravir. It's the drop-off in adherence that leads to the superiority of cabotegravir.
Over time issue that, everyone fatigues over time. Yeah.
No kidding. That is exactly the problem. So anyway, there's a couple of other PrEP studies I want to mention. This is a interesting one from Africa, and it was basically 6-month dispensing of PrEP instead of 3-month dispensing. And then also self-testing. That's what ST stands for in the figure. So we're testing 3 different strategies: 6-month PrEP and oral fluid self-tests, 6-month PrEP and blood-based self-tests, and then they were combined for this analysis, or 3-month PrEP and visits and clinic-based rapid testing. So when you look at this, you're basically saying, we kind of trust you to do this on your own, and we're not going to hold you to this every 3-month part. And the results actually were pretty good. You can see that, if you look at the proportion tested for HIV, the proportion who refill PrEP, the people who are adherent to PrEP, everything looks pretty good. In fact, you'd say that this pretty much meets the non-inferiority threshold, except for one, refilling PrEP at 12 months. Not quite non-inferior, but when you looked at the women participants in this study, actually the self-testing was actually better. Was better. So I think this study is getting at something, and what it's getting at is what some have argued is the over medicalization of PrEP, and I just put our guidelines up here, because our guidelines are extremely aggressive about follow-up every 3 months, not, HIV test, syphilis, gonorrhea, chlamydia, appropriate if people can do it, but you don't want this to actually discourage people from taking PrEP. If the option is every 6-month follow-up and taking PrEP, or every 3-month follow-up and refusing PrEP, I would definitely go with the every 6-month option, meaning that I think you should be able to negotiate with our potentially people who are potentially interested in PrEP. What do you think, Marina?
Yeah, I support that. I think the other side of it too is that, it's a tremendous burden also on the healthcare provider to see people who are otherwise healthy every 3 months. So either removing it from an obligation or making it a lower threshold so that they can do this self-testing or with nurse-led care or some other way of doing the more regular follow-up that doesn't require, a contact with a physician.
Thank you. I agree with you 100%. Okay, so I'm going to now just quickly go through this complex study. This is a study looking. The pharmacists who are watching this don't think this is complex, but for us ID doctors, maybe it is. But it's basically looking at the concentration curves of cabotegravir if you give it in a more concentrated fashion. And one of the problems with cabotegravir injections is that it's pretty high volume, and you can't give it self-administered because you can't give it subcutaneously, so a healthcare provider has to do it. I actually have had to do it recently for the first time myself because our nurses were not available. So it was actually quite a lot of medicine that you're injecting into the muscle there. That was a cabrolpivirine patient. But this more concentrated version could potentially be given subcutaneously, and the patient-reported outcomes were favorable. So maybe that's a formulation that's coming, and that would make it easier. And I don't want to leave this idea of long-acting PrEP without mentioning lenacapavir. Lenacapavir is, in a study right now where it's being given every 6 months for PrEP, and the initial way of giving it was a little too cumbersome. So this alternative way of giving it with an oral loading plus 2 injections, plus 1 injection, was tested. And as you can see from this figure, the concentration curves overlapped very nicely. So this looks like the simplified starting regimen for lenacapavir is going to be the one going forward. Lenacapavir for PrEP is currently in the midst of a well-enrolled study. It's back on. It's started up again because they figured out what was wrong with the formulation, and it's. We don't have results yet, of course. It's being compared to tenofovir FTC, and I think every 6-month injections that could be self-administered sounds very promising for PrEP if it works. So let me mention a few additional PrEP studies just to say that there was a sub-study within 083 looking at trans women in that study who found first that they had comparable benefits of PrEP compared to the overall group of MSM, and also that the gender-affirming hormones had no impact on cabotegravir concentrations. The other important finding in study 084 was that the pregnancy outcomes in that study showed no adverse events. And then there's additional analyses of the TAF FTC versus TDF FTC, which show, not surprisingly, that the lipids drop more with TDF FTC with no change in the total cholesterol to HDL ratio. So I think this might be a good place to take questions if you want to, if they're on PrEP, because I'm going to switch to HIV treatment next.
Yeah, there are just a few questions from the audience. One was really about how actually was there possible to do this double-blind study if the injections cause inflammation? How do people know whether they're getting?
They used a vehicle that actually they didn't use saline. Isn't that amazing?
Yeah, amazing. Yeah,
amazing.
Yeah. It actually is a study that needed to be a double-blind placebo-controlled study, and it's to their credit to have pulled that off because I think it's quite
remarkable.
Remarkable. And then there was some questions about whether or not how many people were not adherent to the CAB injections. Do you recall?
So not many, but the notable thing about this 084 study is that it was clearly associated with failure. One thing that was people were really concerned about the so-called tail end of the PK distribution when the drug is below the inhibitory concentrations but high enough to select for resistance. But that wasn't actually seen in 084 or in 083. What was seen in these studies is that there were a few cases of PrEP that broke through in 083, people who were adherent, and that was the setting in which you saw some integrase resistance. So.
I actually wondered what you thought about the oral lead-in or not, for.
I think it's not
prep.
necessary. Yeah, not necessary, but that's
Yeah.
my opinion.
Yeah, I think it makes
Okay.
some of that, yeah.
You tell me when to go on, or I'll just.
Yeah, I think, there's a few more questions, but I think we're gonna go on just to make sure, and I'll try to come back to these if they're.
Okay, great. So let's start with what I think is, there were like 3 or so studies that were kind of really big in terms of potentially practice changing. This is one of them. It's called Alliance, and it's a double-blind, placebo-controlled trial for HIV hepatitis B co-infection. I think it's the first time there's been a study just in this population that compares two treatment strategies. One was bictegravir FTC TAF, one was dolutegravir plus FTC TDF. So this is a 1-pill regimen, this is a 2-pill regimen, but since it's double-blind, everyone took 3 pills a day. And everyone in the study was hepatitis B viremic. Hepatitis B viremic. So 2 endpoints. One was an HIV endpoint, and one was a hepatitis B endpoint. And if you look at the baseline characteristics, one couple of things to note. First of all, almost everyone in this study was a man, because this study predominantly enrolled in Asia, and the sites that it enrolled in Asia, the epidemics right now are almost exclusively in MSM, and so very, very low HIV incidence in women in these regions. You'll note that it was a fairly advanced disease population, and, a high proportion with high HIV viral loads and low CD4 cell counts, and that these were, like typical hepatitis B viremic patients. They have tons of hepatitis B. The median hepatitis B viral load was 8 log, and 76% in one arm, 80% in another arm are hepatitis E antigen positive. So the results of the HIV part are perhaps unsurprising. So you've got a 95% in the bictegravir FTC TAF and 21% in the dolutegravir FTC TDF arm, and that's not inferior. But what's most interesting in this study are that the hepatitis B outcomes at 48 weeks favored the bictegravir FTC TAF arm, the primary endpoint of hepatitis B viral load less than 29, plus these other endpoints, ALT normalization, E antigen gone, surface antigen loss numerically. So that was actually a very surprising result to me. At least I didn't expect it. But apparently in the hepatitis B literature, there was some hint that TAF might be better than TDF, although it's not strongly so. So your next question, do you think these data warrant a change in guidelines to make TAF preferred over TDF for HIV hepatitis B co-infection? Now, this is a one study, a randomized clinical trial, though, and double-blinded, done predominantly in Asia. So I'm waiting to hear what you think, having seen these results. So, and 75% say, 74% say yes, and 26% say no. And what do you think, Marina?
I don't know. I think like you, I was really surprised by these results, and I'm still scratching my head as if there's not something that went on in this study, but it does appear, and just because the context of the data from hepatitis B monoinfection, maybe there's a slight signal there, but not so strong. And there's been a lot of people exposed. So I think the jury's still out in my view, but it really is intriguing.
Yeah, certainly wasn't expecting it and was happy to see it, because a lot of our tenofovir use, at least in the United States now, is TAF over TDF. So this is moving along. Well, yeah, I remember just one thing about this study before I go on. These are week 48 outcomes, and as everybody knows, the hepatitis B suppression can take some time because they start at such high viral loads, and so maybe at week 96 it'll be even. But I still would argue that all of these really do show TAF better. Okay, so I'm going to just go through this couple of studies, updates on these studies. Famous advanced study. These are basically dolutegravir versus efavirenz studies, but also a TAF versus TDF studies. And you'll see that the intention to treat component of this study shows that dolutegravir is now better. And this almost certainly indicates a better tolerability because the on-treatment results are virtually identical. And It's interesting. I don't think on treatment results for anything has ever beaten efavirenz. Efavirenz, even though it's been around since 1998, very good with years, efavirenz is actually, incredibly potent, long-acting drug, and it's really tolerability. So the big news from this advanced study, aside from the virologic results, of course, has been the weight. And now we have this weight trajectory over 192 weeks. And these are the TAF FTC dolutegravir arm, gaining the most weight, intermediate, the dolutegravir arm with TDF, and then the least with efavirenz. And the weight gain was more in men than in women. And when you used criteria like metabolic syndrome, obesity, etc., they all showed a higher risk for the TAF FTC dolutegravir arm. Remember, these are treatment-naive patients, and the risk factors of obesity were getting this regimen. Baseline BMI was high, female, and advanced HIV disease. So the confluence of all these things, and we recently talked about this in the context of a new diagnosis in our clinic, was a woman who's quite overweight, African-American, who has a CD4 cell count of 90. And, she is going to start a TAF-based regimen with bictegravir, and she is going to gain a lot of weight. And I think we do need to make that part of our counseling. What's really not clear, of course, is whether that's a toxicity or not in people starting the drug. So similarly, Namzal compared dolutegravir with efavirenz, and efavirenz at 400 milligrams. And this is now looking out at a long-term follow-up, week 192. And we have the study results on this slide. And now dolutegravir is superior to efavirenz again, especially in the high viral load group. It does, again, show a greater amount of weight gain in the dolutegravir versus the efavirenz arm. This time, it's not a TAF thing. It's because there is no TAF. This is just basically integrase versus efavirenz. When we do know that this regimen of TDF, FTC, efavirenz, we now know because we've compared it to so many things, it's always associated with the least amount of weight gain. Is that a good thing or a bad thing? We can debate that. So a couple of other observational studies have shown that dolutegravir works very well in advanced HIV disease. I'll briefly mention this non-randomized observational trial looking at proportion of people with advanced disease, really advanced disease, CD4 less than 50, and demonstrating that the dolutegravir regimen was better than the efavirenz regimen. Now, this is, again, not a randomized comparison, but I don't think anyone is arguing that advanced disease patients should be treated anything else but bictegravir or dolutegravir-based regimens, and these data at least would support that. One other long-term study that I was asked to present these data, these are people who enrolled in the original bictegravir pivotal clinical trials. So 1489 compared with abacavir, 3TC dolutegravir, that's a typo there, and study 1490 it's not a typo, it was placebo. And study 1490 compared to dolutegravir plus FTAF. And so what this analysis did was it looked at just these people initially randomized to bictegravir and just followed them for 5 years. And the 5-year follow-up, again, these numbers look familiar. They look kind of like the advanced study. If you're looking on treatment, everyone's successfully treated. And, we really have achieved that with our HIV regimens now. It's just amazing. Everybody who takes their meds pretty much gets suppressed. But there is some dropout in the study over time. So missing counts as failure in the second analysis. This is a study that, as has been widely discussed in this study and the dolutegravir studies, there's been nobody who's developed resistance. And none of the patients with failure have developed resistance at all. So it's just amazing the high resistance barrier of these dolutegravir and bictegravir-based regimens. Here's a little bit of a pandemic message. Weight gain is greatest at the outset when you're returning to health, and then it sort of clips along at about what people gain per year on average, a little under a kilogram. And then during the pandemic, there was this increase. And when I saw these data, I wanted to make sure that there are population-based norms on this, and there have already looked at this, and the population during the first year of the pandemic did gain weight, that we became heavier as a society, probably due to inactivity more than anything else. So one more study on weight, and this time it's not a naive study, it's actually a switch trial. And there are two trials, one called Tango and one called Salsa, and they're both dances. And they're both chosen because it takes two people to dance them, and this is dual therapy with dolutegravir lamivudine. And it turns out the weight changes in this study depend very critically on what the nucleosides were at baseline. So if you're already taking a TAF-based regimen at baseline and you switch to dolutegravir lamivudine, there's going to be no difference in the weight changes. Dropping the TAF to dolutegravir lamivudine does not change weight. So that's a very, very important observation. So people shouldn't switch people off TAF FTC X to dolutegravir lamivudine in the hope that they're going to lose weight, because I don't think that strategy is going to work. By contrast, if your baseline regimen contains TDF, then switching to dolutegravir lamivudine gives you a change in weight that's very much like switching to TAF. It's pretty much the same, 2 kilograms over 48 weeks. And if your baseline nucleosides are abacavir lamivudine, it's somewhere in the middle. So I think this is giving us a really nice picture, taking away the return to health phenomenon that is seen in treatment-naive patients, of the effect of baseline nucleosides on weight, and that TDF clearly seems to be suppressing weight. So this is an essay question. There's no actual way of putting this into a multiple choice. What do you think? What do you think? What do we know about this at this stage of the game?
I think the more pieces of information we get, the more hard it is to sort out an overarching message, which I think and there's clearly some people who are more at risk for this to occur. And we saw that really well demonstrated in some of the earlier studies, and particularly coming from African settings, where, and in women in particular, the TAF plus integrase inhibitor seem to be, particularly harmful. But then there's, we have these comparison drugs which may actually be suppressing weight. So the same would be true for TDF as for efavirenz, right? So what do you think? So maybe it's not that there is weight gain, it's just that there was no weight gain when you were on these other agents.
Yeah.
So the switch studies are sort of helpful to us to try to tease that bit out. But these are people who are already stable on those regimens. And so I think anecdotally, we've all seen this happen. Anecdotally, we've all seen people who, I've seen this happen and then switch people back off what they're on and they've lost the weight. So there is some phenomenon there that is happening. And I think we really have to understand it mechanistically a little bit better. I think it's a combination.
They only seem to lose weight if you put them back on TDF, in my experience.
That's been sort of back to Jen Boya. And she was on, so she went to a TAF, it was taking her off the bictegravir and back to elvitegravir.
Oh, really?
Really? Yeah.
Interesting. Yeah. So there you're getting the.
So that was one, and then one though, so you can't really generalize. Yeah.
Well, it's a very tough issue to address, because our patients are convinced that pills are doing it to them, and it's very, you don't want them to take something toxic just so that they'll lose weight. On the other hand, some of the weight gain is quite substantial. So anyway, so that I've already mentioned that the Alliance study, which is the study, one study that I wanted to highlight is really important, the hepatitis B HIV study. But this one also I'm going to highlight now. And remember, cabrolpivirine, according to our guidelines, is an optimization option for patients who are engaged with their health care, virologically suppressed on oral therapy for 3 to 6 months, and who agree to make the frequent visits needed to receive the injectable drugs. That's what our guidelines say. But I want to mention this study because it was actually published at the same time in CID and presented at this meeting. And this is a remarkable observational pilot project at the UCSF Safety Net Clinic, Ward 86, which has a very high proportion of patients there who have substance use disorders, psychiatric illness, unstable housing. And they started a program of cabotegravir rilpivirine for them, very ambitious. 132 were referred, and 51 actually started injections, and they presented follow-up on 35. Now, they have unbelievable resources at this clinic, and it's just amazing how they get it. I'm very jealous. And then they reported the outcomes, and I really don't want to talk very much about the people who were suppressed when they switched. I want to talk about this group. This is 15 people who were not taking any oral ART and on average had quite advanced HIV disease. So CD4 of 99, a viral load of, actually that should be just under 100,000. 50,000. And one of the participants in this actually had a resistance mutation to raltegravir, and they went on cabrolpivirine because essentially they wouldn't take anything else. They were very difficult to treat because it was so difficult to get them to take the oral medicines, but they agreed to take the injections. And all had this nice antiviral response, and nobody has treatment failure resistance to date. And I happen to know, because I've spoken with the investigators, that they now have several other viremic patients they've treated this way. So provocative question for all of you. Would you consider this strategy for a person with HIV who will not take oral ART? And remember, this is not the FDA-approved indication by a long stretch of the imagination. This is actually exactly the opposite sort of people you would normally choose to treat with cabrolpivirine. So we're going to see what our audience of HIV experts is going to say. Let's see the results. So 74% are convinced by this case series of 15 or so, and 12 said no, and 14% only if they had advanced disease. And I actually think that's how I view it. If someone has a CD4 cell count of 500 and they're not taking oral ART because they just can't get their act together to do it, I would work with them to try to figure out what it is. But if they're now CD4 is down under 100, then I would consider this strongly. We've done this actually for one person in our clinic, and it has worked. So what do you think, Marina?
Yeah, I have to agree with you. I think, when there's no urgency and you have time to work with somebody and try to see if there's other options. But it's a rare person who's really not opposed to being treated, but cannot manage for whatever reason to consistently be on oral therapy. And I guess in this study, they had good follow-up and they were getting their injections, because really it's the forward the forward follow-up that also matters, not just
one of the people in this study was not coming in, and they had a mobile van that went out to find them and gave them the injections in the van. But just by the way, someone asked for the reference. It was published in Clinical Infectious Diseases just recently, and this is the first author is Christopoulos et al. So now I'm going to not push you too hard on this one because we want to actually get some data on this, and it seems like it should be studied rather than just here's our anecdotal experience. And the ACDG tried to do a study of this, and is trying, and our study is very complex. It's called ACDG 5359, long-acting cabrolpivirine in non-adherent persons with HIV. And so let me just take you through it. So we start with step 1, which is that people have to get suppressed first on oral ART, and they get financial incentives to get suppressed. So each of these dollar signs is times they get paid, and the payment is put over here. There are some behavioral science studies that say that this is the right amount to pay them. It's not it doesn't cross over into being unethical. And then there's a randomization where they get injectable cabrolpivirine or standard of care. There's no longer a requirement for an oral lead-in, but you notice how some stay on standard of care. And then at week 72, they get everyone gets the long-acting injectable. So I think the study is really nicely designed scientifically. It has been extremely difficult to recruit. We initially recruited quite well in the United States, and now we've hit a wall. I think that everybody has the kind of patient who might be interested in this, and then you start realizing that most of the people who are not engaged in care, they're not going to get engaged in a clinical trial either, especially one where they might get randomized to get oral therapy. So anyway, I'm going to finish up this section on HIV treatment with a few other quick comments. One is that lenacapavir resistance does occur. Lenacapavir is currently under review by the FDA, will likely be approved by the end of this calendar year. And it is going in treatment naive. The risk factor for lenacapavir resistance was poor adherence, and in the treatment experienced study, it was either poor adherence or zero active drugs in the background regimen. These are the Calibrate and Capella studies. There was another study looking at self-administration of cabopivirine in the lateral thigh. It seemed okay. Dolutegravir rilpivirine was tried in patients who already have NNRTI resistance. It seems to work. I don't know why you would do it, though. Darunavir ritonavir plus 3TC, the Andes study showed that it was not inferior to triple ART. And then there was a switch study looking at dolutegravir plus FTC. Here, it did seem to work. It was not inferior to continued triple therapy. But again, I would just say that if you have a co-formulated dolutegravir 3TC, I can't think of what the advantage of dolutegravir FTC would be. But I just thought I would mention it. Okay, next section is on complications and co-infections. And amazingly, I'm not going to include any COVID-19 in this entire section. Let me just mention monkeypox. Actually, these data, I'm sorry, are a little outdated, but obviously cases went way up, and now they're coming down, fortunately. And they've been reported from essentially all over the world now. And the Montreal experience was summarized here. And plus, they've been giving the vaccine. You're giving a different vaccine from the one we're giving, right, Marina?
No, it's the same. It just has a different name here. It's, yeah.
Oh, the Jynneos, you don't call it Jynneos?
Yeah, we call it Imvamune, but it's the same vaccine. Yeah.
Okay,
but
never mind
we're giving it as it's not subcutaneously, at least in the initial phase. This was being done at the full dose.
Okay.
Like what's being done in the US. Yeah.
The thing I think is most notable about this vaccine is that it was approved for treatment of smallpox, and based on antibody levels, it's never actually been tested because there's no smallpox. So we're just hoping it works. I don't know if we're going to ever see efficacy data. Obviously, some people don't get protected, but maybe because it was given too late. I don't know. Are we going to see efficacy data on this? I don't think so.
Well, there's a lot of people trying to work on how do we design vaccine effectiveness trials based on the rollout, because we only have that data to work with, and it's complex because we're looking at various different ways to do that. But there's I've seen updated data on the vaccine failures, and there's clearly are at least, I think, almost 30 or more now that have occurred after 21 days of the vaccine.
Really?
But there's still no clear timing of last exposure on those people. So it is possible. And there's a slight hint that people who received that vaccine may have had less symptomatic disease if they did fail after a vaccine. But yeah, I think the jury's still out on how protective it will be, and especially if it's a single dose and if you don't get the second dose. Yeah,
we are encouraging all of our people at risk, and we're defining people at risk in the United States as people who have had a known exposure to monkeypox, or people who are sexually active with MSM in a region with endemic monkeypox, which is almost all the urban areas in the United States. Although, interestingly, I was talking to someone recently from Springfield, Massachusetts, which is west of Boston. You may or may not know that because there's a Springfield in every state, but Springfield, Massachusetts is about an hour and a half, 2 hours west of Boston. And they've seen hardly any monkeypox there. We were seeing a whole lot for a while, but now we're seeing way, way less. I don't know. What's your experience in Montreal?
Yeah, things have definitely plateaued and have started to fall off in the last couple reporting periods.
Good news.
Good news, yeah.
Well, I want to mention, very importantly, this was not presented at the meeting. This is a clinical trial that the ACDG is running on tecovirimat, which has in vitro activity against this virus. You'll note that there's a randomized component where people who have monkeypox that is mild to moderate in severity are randomized to tecovirimat or placebo, but if it's severe, then they get open label drug, and the criteria for severe are listed in this part of the slide. It just opened in the United States, and right now simultaneously there's a study going on in the United Kingdom. We don't actually know if tecovirimat works for this, but there's a lot of anecdotal comments that it does. So better to find out. Remember, if you think back to the SARS-CoV-2 days, early days, there was a lot of anecdotal evidence that didn't pan out, and it would be good to know if this actually does work.
Yeah,
So I do want to just highlight something that the chapter, maybe this will be the last chapter in this story. I don't know if you remember, but back in 2018, all of us suddenly stopped what we were doing. If we took care of people with HIV who were of childbearing potential, and found out that there was almost a 1% incidence of neural tube defects in women who conceived while receiving dolutegravir-based regimens. It was very, very small numbers, but it was much higher than would be expected. And then since that time, it's gradually declined. And so right now it's a tenth of the incidence it was before, and it's now no different from other ART strategies. So all of those teaching slides on dolutegravir and risk of neural tube defects, perhaps we can delete them or never show them again, and just show this and show it as reassuring that no one really can understand what exactly happened and why there was that cluster of cases that prompted the warning. I'm glad they warned us, but at the same time, now it's much clearer. And this is now, at least in the United States guidelines, the preferred integrase inhibitor for use in any phase in pregnancy, whether it's women wanting to conceive, women who have childbearing potential, women who start ART during pregnancy. It doesn't matter. It's dolutegravir-based regimens. And by the way, TAF-FDC is now the preferred nucleoside combination. Now, I mentioned two main studies I wanted to highlight. One was the Alliance study of HIV Hep B, and one was the cabrolpivirine in viremic patients. But I wanted to actually highlight now, this is the third and final of the three big studies I'm going to mention, and it's called DoxyPEP, which is doxycycline post-exposure prophylaxis in two populations, MSM and transgender women who are HIV positive, and also MSM transgender women who are taking PrEP. And the requirement here is that they actually have a bacterial STI in the previous year. So one or more STIs in the previous 12 months. And then the randomization, it's open label trial, is to take doxycycline 200 milligrams times 1 after condomless sex within 72 hours, or not to take it. And you can see the study population is at the bottom of the slide and how well they adhered to the regimen. And here are the results. The results showed that for all three bacterial STIs, chlamydia, syphilis, and most surprisingly gonorrhea, there was a significant reduction in the risk of getting these. And why I say most surprisingly gonorrhea is because the previous study, which was done in France and which was a sub-study of Ibergay in PrEP takers, did not show any reduction in gonorrhea incidence. And the explanation was that there's quite a lot of gonorrhea resistance in France. So this brings me to my next interactive question. Should doxycycline post-exposure prophylaxis be incorporated into the STI guidelines and make it official? Make it official. Yes or no? Yes or no? And you're going to vote. And you'll be happy to hear I just have one more section and one more interactive question for you. Well, actually, a few more interactive questions. But first, you have to vote on this one. So what do you think? Let's see the results. And 73% say yes, 27% say no. Your opinion.
Yeah, I think this is quite compelling. I think the evidence is really growing, and it does, especially for people who have recurrent, STIs. I think this gives them an option to reduce that and hopefully have some populational effect. That would be really interesting to see
Yeah.
if it.
I think, I agree with you. I do think it's important that we look at the patient criteria, the enrollment criteria, that people,
Yeah.
these are people who've had STIs in the previous 12 months. So we want to only do this for people who really could benefit from it.
We also need to be concerned about, surveillance long-term over development of resistance, is something that may see. Yeah.
Great. My last section is called Cure and Almost Cure. There's a new cure, City of Hope patient. This is an older man, diagnosed way back in 1988, before the first Montreal AIDS meeting. That's amazing. Low CD4 nadir. He gets diagnosed with leukemia. Like the other cure cases, an allogeneic hematopoietic stem cell transplant from a matched, unrelated CCR5 delta 32 negative donor. So these are people who have cells that are uninfectable with HIV. And then he gets to be listed on this chart. There's 3 other cures that are well documented. There's a 5th cure from Dusseldorf that we don't really have follow-up on, but you can see this one has some differences between the others. Probably the immunosuppression he received was the least intense, probably because he's an older person. Remember, immunosuppression is less well tolerated among the older people who get transplants, and he did have an infectious complication. And then lo and behold, like the other people, they stopped ART, no viral rebound. Core antibody, Hep B core antibody remains positive, interestingly, but there's no HIV immune responses anymore. So, these are probably cured. It's been 108 weeks, no rebound. Now that is not going to be scalable, And by the way, the other thing about this, you see this table and you go, well, let's do this for every transplant. But in fact, there are some misses. There have been some people who got this strategy who did not get cured. So it's not working all the time, but at least it adds to the numbers. And then there's this other case, I said almost cure. This is called exceptional elite control without ART. A 59-year-old woman treated during acute HIV and then got this sort of grab bag of immunotherapies. It was a study in Spain where they kind of threw the kitchen sink of immunomodulators at their people treated during acute infection for reasons that they probably had a theoretical reason why they did it, but I can't tell you what it was. And then she has undergone 2 treatment interruptions, but the second one has been 15 years without virologic rebound. And, there's this, she has very incredibly intense immune control that was very well documented. One thing to prove that she's not cured is that she had what's called a positive quantitative viral outgrowth assay at year 9. So anyway, it's an interesting another case report. I know as the editor of a journal, I should be very cautious about reporting on case reports, but sometimes case reports are very interesting if they're very well described, and I have to say this one really was. Okay, any thoughts about the cure case or the elite control case, Dr. Klein?
Yeah, I mean, the more we can tease these out and understand what's functionally behind them, the more it can inform our strategies. I think, as you mentioned, they're not actual ways to cure people, but really more what we can learn from them about how to cure people, I think is the
great
message.
All right, my last question. What is this? An animated abstract cartoon character, the abbreviations for the late, great John Bartlett, it's JB, the M on the baseball cap of the Montreal Expos. Let's see whether you can vote and tell us what this is. And I think you might get the answer. 88% got it right. I'm a little disappointed in you.
That's good.
10% said John Bartlett, and some thought it was an animated cartoon character. This, in fact, is the M on the cap of, these are some Hall of Famers who were on the Montreal Expos. One of the saddest thing about this baseball team is that in 1994, they had the best team in the National League, and then there was a baseball players' strike. Do you remember? Do you remember that?
Remember that. Everyone
Okay.
remembers that
Anyway,
here.
they're now in Washington, D.C. So, all right. So, greatest hits. I've highlighted the 3 studies at the top here that I think we all should remember. The Alliance study, BIC, FTC-TAF versus TDF3TC for HIV Hep B co-infection, Doxy-PEP versus placebo, doxycycline versus placebo after sex to prevent bacterial STIs, and cabrolpivirine in people with HIV with adherence challenges in viremia, promising very early data. I've listed a few other take-homes here at the bottom. But now, in order to get to the question and answer period, we have to do the post-test questions. And we've already done these before, but now we're going to see whether your answers get even better. So this is that person with HIV hepatitis B co-infection. Which of the following initial therapies should be chosen? Abacavir 3-TC dolutegravir, bictegravir FTC TAF, dolutegravir lamivudine, or TDF 3-TC doravirine. All right. Let's see what you choose. And the answers are coming right up. And let's see them. Okay. Yes, there has been improvement. 93% chose the TAF-based regimen, which we do think looks very promising. And the other thing about these is that you wouldn't choose A or C because they're not tenofovir-based, and D is not, at this point, a guidelines recommended initial therapy, at least in the DHHS guidelines or IAS-USA guidelines. All right, next question and the last question, then the Q&A period. Your patient has been treated 3 times for bacterial STIs over the past 2 years. He's currently on CAB every 2 months for PrEP, injectable. Which strategy reduces his subsequent risk of contracting HIV? Contracting another bacterial STI. Switching PrEP to oral PrEP, cefixime, doxycycline, or monthly benzathine penicillin. Okay. And 99% get it. So excellent. So we have had some very nice learning, and now we get to hear your Q&A. I'll stop sharing. Okay.
Thanks so much for that really excellent presentation and really great overview of the best studies. I think there's a lot of interest actually in the Alliance study from the questions if I'm looking over them, and really so first of all, what might have explained that difference or that was observed, and one person brought the point up was maybe could there have been a difference in adherence between the 2 arms because the dolutegravir TDF FTC arm would have been a 2 pill regimen versus a single tablet regimen. So that was one point.
It was placebo controlled, so everybody got 3 pills. Yeah, so the adherence was the same in both arms.
It should have been the same. And I think one point of clarification, which I think is worthy, someone raised in the questions about the dose of the TAF contained in the bictegravir TAF FTC combination versus what would be used for hepatitis B monoinfection. But to my knowledge, it's 25 milligrams, I think, in both circumstances. So I don't think that there's a difference. But
I have never used TAF as a monotherapy for hepatitis B, so I don't know the answer.
It's not here. It's not approved yet, except when you need it for people who've developed complications with TDF. So
interesting.
Yeah, for monoinfection. Okay, and then I think some people were. I guess the message too about how important it is to consider hepatitis B when we're selecting our first line treatments was probably worth making, especially in the context of a lot of discussion now about the injectables, which don't typically thus far have activity against hepatitis B. So maybe a point to reiterate.
I just looked it up real quickly using the miracle of the internet.
You're faster.
The fact that you're looking at the Q&A, I could look it up. The dose is the same.
Yeah. Okay, great. That's what I was.
25 milligrams.
25 milligrams. Yeah. So, and then question about the weight gain. Any studies yet that looked at weight changes with the cabrolpivirine combination?
So if people are on baseline TDF and they switch to cabrolpivirine, their weight goes up more than if they're on baseline anything else. Early data only, but that's what's been observed. So
Mhm.
Remember, one of the studies, the baseline regimen was abacavir 3-TC dolutegravir. That one, there's really no change in weight.
Mhm.
So if you stop, I pretty much guarantee when you take someone off TDF-based regimen, you almost always are going to see something. And just so counseling people that they might gain weight if they're stopping TDF-based regimen is time well spent. So.
Yeah, I think that's an important point, because it's not just this new pill might cause you to gain weight. It's what we're coming off may have not
Yeah,
kept you from gaining weight. And this
exactly.
is,
Just saw someone who moved from South America, and he's on TDF-FTC efavirenz, and he said my doctor in South America was going to switch me to TLD. He didn't use that term. He was going to switch me to tenofovir, lamivudine, dolutegravir. Should we just make the switch here? And I was like, let me just go through it with you just so you understand. If you come off of that regimen, even if it's just switching to dolutegravir, you might gain weight. In fact, the first observation of weight gain with dolutegravir was actually people switching from TDF-FTC efavirenz to abacavir 3-TC dolutegravir. So it's just that regimen, TDF-FTC efavirenz, strongly associated with weight suppression and for reasons that are still not clear. Grace McComsey thinks it's some sort of, not mitochondrial toxicity, some sort of muscle toxicity. Not sure exactly what, but or fat toxicity, something related to a change in the cells. Yeah, I wish you were here to explain it better than I did.
So it sort of begs the question, I guess, too, is, and you showed some of this data about how efavirenz, among people who take TDF, FTC, efavirenz over the long term, they really do exceptionally well in terms of their virologic suppression.
Yes.
And so, should we, if there are still people out there, I know there are still people out there.
There are. I have some.
Should we be encouraging them to switch or not?
So
this is, I think.
My strategy is that the people who have zero side effects on efavirenz at this point, at this late date,
yeah,
there's really no reason to switch them. A lot of the ones who switched already, they felt great coming off of efavirenz because they didn't realize how kind of drowsy and dizzy they were. But then now, it's been years they've had the opportunity to switch, and some of them actually feel worse when they switch off of efavirenz because it's kind of got a sleep-inducing effect. So I don't really switch. I do think that long-term TDF, especially for our older patients, is not a good drug. The renal and bone effects are to be avoided. Since I've been doing this so long, I have a lot of old patients, and it's just there's so many different potential causes of renal and bone disease in older people with HIV that I'd like to get that out of the equation.
Yeah, I think it's also fair to say, one of the consideration that we don't often discuss is the cost considerations too, because, it is generic here. Presumably
yeah,
in the US
it's
as well.
generic.
And in low and middle income countries too, I think the accessibility and cost, if it's working well, I think it's still a regimen that really does address the HIV side of the regimen.
Totally.
Okay, so there was one, it's more of a point that someone made, but I think it's worth it in terms of the people who aren't taking oral antiretrovirals, but go on to cabraclovirine, and that there's no urgency if they have a high CD4, but maybe to consider urgency if someone is, engaging in sexual activity where they could transmit. So could this be a kind of a way to reduce the risk of onward transmission in someone who is sexually active and is affecting drugs? Yeah.
It's a good point. There's so many benefits for people to be on ART versus not on ART, but the benefits are most dramatically accrued for people with advanced HIV disease.
There's some questions about, sorry, I'm just going. Yeah, go ahead.
One issue I've heard in the United States, because, our healthcare system is so fractured that some people can't get cabrolpivirine for a patient unless you prove to the payer that they fully meet the criteria that's in the package insert. Mm-hmm. And clearly that was not the case at Ward 86 in San Francisco. They obviously had a very permissive system of paying for the drug that undoubtedly came through government assistance. But if you go to, you know, I'm just going to choose out of a random southeastern state, Mississippi or Louisiana, or I doubt that you would have the same sort of very generous coverage as they did in San Francisco.
Yeah.
But maybe
And-
someone from Mississippi or Louisiana can chime in and correct me if I'm wrong.
And someone also wondered if enthusiasm for this strategy might be dampened if they had very high viral load, for example.
Well, one of the patients in the study, one, careful, had a viral load of 6 log,
Wow.
and that person responded. So, you know, it's just a tribute to, I think, the potency of our modern regimens, and that in order to really avoid untreated AIDS, we should do extraordinary things. I mean, one anecdotally, and perhaps you've had the same experience, we've had people admitted to the hospital not because they can't take any ART with complications, who then end up needing like a G tube so that they can get ART given to them that way. You know, this seems to me like would be a better option than that. One of the big concerns, of course, is that it won't be sustained and that people will then get resistance. And once you have this will almost certainly be 2-class resistance. There'll be resistance to cabotegravir and rilpivirine, and then you're stuck having to use a boosted protease inhibitor-based regimen, which is the hardest to take. So it's not going to be 100%, that's for sure.
Yeah, I mean, I think we're talking about some exceptional circumstances.
Exceptional, exactly.
Options, yeah. So it looks like we're past the 15-minute mark, past the hour. So I think and most of the questions. So I guess I'll take this opportunity to close things up, and thank you once more for a really fabulous presentation, interactive and a lot of fun.
Thanks so much, Marina. Appreciate it. And thanks to everyone for joining us today.
Thank you, Dr. Sachs and Dr. Klein, for a very informative discussion, and Dr. Sachs for your excellent presentation. As a reminder to our audience, evaluations and information on how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. Here are a list of upcoming webinars that we have. Next week, we will have a HIV 101 webinar with Dr. Sag and Thompson. And today is the deadline to submit general abstracts and scholarship submissions for CROI. For more information, please visit our website. And the Ryan White HIV AIDS Program Clinical Conference is open to Ryan White clinicians. For more information, please visit our website. And lastly, we have a December 8th course regarding the 30th annual update on HIV management in Chicago, Illinois. Again, this concludes today's webinar, and we'd like to thank Dr. Klein and Dr. Sachs. Thank you.
Thank you, Jose.
Thank you, Jose. Thanks everyone for being here. Great.